was too long. Well, this is the man that introduced BTA in abdominal wall surgery, plastic surgeon from Mexico, Guadalajara. I met him there and I've learned a lot from him, and we still communicate until today. Well, neurotoxin botulinum is probably the strongest poison ever. It is something very special because, of course, military interests being used in wars and prolonged intensive care among affected persons. You will understand because of the pharmacology of BTA. Well, a single gram could kill more than 1 million of people. Well, what happens when you let journalists talk about the work that we do? There was a congress in Salzburg. I've been talking about BTA, Botox, and they put it in the newspapers and saying, well, this from major bioweapon to wonder weapon for groin hernia surgery, which is a nonsense. Nobody uses it for a groin, but for the abdominal wall. But this is what happens. This is called fake news. Well, so let's use the correct expressions. Botulinum toxin is a group of different serotypes. Botox is a trademark, and still people, when they talk about botulinum, they always say Botox. There are different botulinum toxin A's, and it is important to differentiate them. They are not the same. The dosage of BTA might be depending on the product itself. Well, you see several names here. The most known, Botox, Dysport, Azalur, even the Chinese version, which is called, difficult to read. Well, something new on the block. Until now we were talking about BTA, cell group A. And there is a BTB now, and this is a new substance that promises much earlier and faster effect. That would be important maybe in emergency cases, open abdomen cases, because you will see, depending on the stuff that you are using, BTA, you will have to wait 3 to 4 weeks until you get the full effect, and this is only used in elective surgery. The BTB is promising something for emergency surgery, open abdomen after 7 days would be nice to have. What makes a hernia complex? Well, there was a group around Dr. Slatter who tried to create criteria for complex hernia, complex abdominal wall hernias. There are 4 categories and 3 severity classes. Severity classes just tell us and guide us for perioperative planning, the risk of complicated postoperative course, and of course the financial cost, which is a part of treatment of such hernias. Well, size and location may be the most important chapter of this is the loss of domain. Loss of domain over 20% if you are using Tanaka's formula, or 25 if you are using SALAC. The things are the same, but a different kind of mathematics. Contamination, soft tissue condition, of course, denervated muscles, open abdomen. The patient history and his risk factors was just normally not being able to change when you're getting ready to surgery. Comorbidities, some of them you can optimize, some of them are just given. Well, the increased intra-abdominal pressure in obesity is its entity on its own. All previous wound resistance and previous mesh infections make the scenarios difficult. Well, emergency surgery makes it more difficult. If no primary closure is possible without component separation, again, that can make even smaller hernias complex hernias. So let's get back to what it's all about. Well, large hernias, W3 or W4 doesn't exist, but they call it giant hernias. The main objective is to reconstruct the abdominal wall integrity in order to restitute functionally abdominal core. Closing large defects carries the risk of abdominal compartment syndrome. And what is meant by that? I think this expression is quite good and easy. Loss of domain expresses the relationship between hernia and abdominal wall or abdominal cavity volume, and it is used to predict the operative difficulty and the success or not success. Well, there are many facilitators of abdominal wall closure, different surgical techniques. I will just concentrate on that temporary chemical component, relaxation of BTA. Well, there is something new on the market called fascial TENS. I've been talking about it last year. It's growing. The use is so obvious. It's the intraoperative fascial traction, just to facilitate the elongation and flattening of the abdominal muscles in order to achieve primary closure, which is the main goal. This is what this slide actually says. The lower the intra-abdominal pressure at the time of the closure, of course, the lower the risk of abdominal compartment syndrome. It's a logical preoperative optimization with patients of loss of domain. Well, we all know in the past we had difficulties because BTA is still off-label everywhere in the whole world, but still it's used nearly everywhere since. Well, this is a temporary effect, so if there is a way to be able to avoid component separation just by facilitation of the closure by BTA, so this is a good step, because temporary versus something which is definitive change of abdominal wall structures with component separations. Well, that's why components relaxation. Where to inject? People talk always about medial clavicular line, first axillary line, or whatever. No, there where the muscle is. Take a look at your CT scan, and then you know where you have to inject it, because this is where you need the relaxation. That's the place of the effect. Well, there are two different theories, 3 points infiltration, 5 points infiltration. I don't know if it really matters. I learned it from the first author, Thomas Ibarra. That was 5 points. I always use 5 points on both sides. Well, it can be even so. Well, this is very logical. This is a paper by Thomas Ibarra, where he used 18 infiltration points in order to increase the hole capacity. This patient does not have a midline hernia, but he needed the relaxation of the rectus bilaterally. So this is just an example of where to inject, there where the muscle is that you want to get relaxed. How? The dosage is muscle mass dependent. Normally it is 100 units on both sides, or 300 units of Dysport. As I said, they are not equal, these different BTAs. Well, this is a good example, pre-operative situation and the post-op situation. The distance anterior-posterior changes, but what changes the most is the transversal measure. As you see here, the patients get large and flat. The hernia in the meantime gets smaller, the content of the hernia gets smaller, and even the orifice of the hernia after 4 weeks gets smaller. Here it was 5.3 centimeters, which is quite a lot for a hernia like that. Well, this was my first patient in 2013. That was just 4 weeks post-operative, 1 year later. And this is what we live since then, because we got used to that when we do elective surgery or patients with hernias bigger than 12 centimeters, we use Botox preoperatively. As you see, Botox 100 units, Dysport 250 or 300, the Chinese 150 units, and maybe again here I don't have any personal experience with it. I've learned it from Michael Scott from England about the Maya block, and I don't know, there is not much literature about this BTA product yet. Well, how do you use it? If you have a good ultrasound, you can inject it directly in the muscle, but to visualize it this way, like you see here, it seems like very, very easy. Well, the retracted muscles do not look like this in reality. Well, the Mexicans are a little simpler. You know, just you measure your needle, you know the depth, how deep you can infiltrate, and then you just go back. Well, it's done in 5 minutes in a setting which is much less complicated. Well, discussion about quantity, dilution, and safety. Well, the Australian group from Sydney found out that the 200 units were as effective as 300 units, so everybody went back to 200 dilution. The Mexicans dilute only with 20 milliliters for 10 points, that means 2 milliliters per point. And the Australian have sometimes 25 milliliter per point intramuscular in a muscle of this size, 25 milliliters. Thank you. It's not, I don't feel that this is the correct position. Well, the Scandinavians were, of course, preoccupied because of the safety. What happens after the injection? Nothing. Well, of course, we say to patients, please don't drive the same day and so on, but they ought to, you know, when they come from abroad, they come with their car and go home with their car. It's their own problem. Well, unloaded skeletal muscle undergo characteristic atrophic changes. So it means the longer you wait until your elective surgery, the more ground you lose. Of course, when the patient had an infected situation, so you have to wait 6 to 9 months, but waiting for 2.5 years and just pushing the problem away, which is the most of the times that the patients come after 2 or 3 years, they are just 1 or 2 years too late. Well, the muscle fiber composition will change too. Again, rectus is a moving muscle. Transversus is a stabilisator, and these are 2 different structures. And this is I had to learn with the time, because these muscles over the time they will get fibrotic, stiff, and make the repair even more difficult. Well, I just don't want to repeat that. Disuse atrophy, it is called. So it makes sense when you have a plan when you're going to repair the patient. Don't wait too long. Well, maybe we can skip that. There's a paper from Argentina demonstrating that you can avoid component separation even in hernias over 12 centimeters by using Botox. So let me conclude. BTA has a strong potential to facilitate complex repairs. BTA with or without progressive preoperative pneumoperitoneum increases the primary closure rate, and that's what we are talking about. BTA decreases the postoperative pain perception in 2 different modes. One comes very, very early, so it's not just a relaxation that causes less pain. Already on the 3rd, 4th day, the effect is here, and this was demonstrated by lowering the number of morphine units after similar operations. So there is, in my eyes, clear indication for BTA in complex hernias, and although it is off-label therapy, it's used everywhere I know. Well, in some countries in Europe, the healthcare systems just cover the cost, although they don't have to, because it is still off-label. It's the same in Switzerland. Well, I'm very happy that after several years of trying to convince all these doctors that decide whether they pay or not pay, they pay by themselves today because they are happy that we are doing it. We have better chances for success. The preoperative optimization is essential to obtain the best possible outcome in terms of fascial closure rate. And I would like to raise your attention because in India next month, there's going to be a huge hernia congress called Deep Impact, where all these great people